The next presenter will be from KEM Hospital, Mumbai.
Yeah, 16-year-old male, resident of Latur, presented to us with presenting complaint of exertional dyspnea since past 4 years, abdominal distension since past 2 years, and easy fatiguity past 1 year. Patient was all right 4 years back when he developed breathlessness, which was insidious in onset and gradually progressive over the period of 4 years.
Sorry, what is the age of the patient? I didn't get that.
16 years, sir. 16 years.
Oh, 16.
Yeah. Initially, patient was breathless on running, cycling, and playing with his friends. It gradually progresses over the period of 2 years, such that now he is breathless on walking even one flight of stairs and doing his daily activity. Suggestive NYHA class 3. Patient complained of exertional fatigue since past 1 year. However, patient denies any breathlessness in lying down and also denies history of nocturnal awakeness due to breathlessness. Since past 2 years, he developed gradual onset progressive abdominal distension, which was associated with abdominal discomfort, anorexia, and easily satiety. However, it was not associated with any yellowish discoloration of sclera or a high colored urine and without any swelling over lower limbs. There were no history of fever, cough with expectoration, hemoptysis, no history of rash, joint pain or swelling over joints, no history of chest pain, palpitation, syncope and pre-syncope, no history of cyanotic spell or squatting in the past, no history of recurrent LRTI, no history of pulmonary tuberculosis in past or treatment, no history of asthma or renal disease, and no history of chest pain, prolonged fever, and peripheral signs of infective endocarditis. So my summary is a 16-year-old male presenting with complaints of exertional dyspnea since past 4 years, not associated with orthopnea and PND, with abdominal distension since past 2 years, not associated with bilateral pedal edema and easy fatiguability. So based on
go back, yes. Please. Go back. So abdominal swelling, go back. No. The summary slide.
Yes, sir. Summary, sir. Yeah.
So abdominal swelling. What do you mean by abdominal swelling not associated with bilateral pedal edema? What are you trying to say? I didn't understand that.
Sir, abdominal distension was not associated with pedal edema. It was predominantly abdominal precoxer. So that is what I was.
It was predominantly? It was predominantly, sorry?
I think they lost the connection. We can hear you.
Hello.
Tumetia.
Sir, could you hear us?
Yeah, very well. Dr. Goel was asking you one question. Please answer that.
Yeah. This swelling, but not associated with pedal edema. So you made it in the summary. So what are you trying to say? I didn't understand that.
Sir, patient presented to us with exertional dyspnea along with easy fatiguability, abdominal distension, but it was not associated with pedal edema. That is what I was saying, sir.
So how do you interpret this? Not associated with pedal edema.
Sir, that it may.
How is it understanding wise different?
Sir, it may signify abdominal precoxer, predominantly abdominal precox, that is usually may be seen in right-sided lesions, right-sided heart involvement.
Hey, right-sided heart involvement. I don't know if some other examiner is getting that point. I am not getting that point. Because what is abdominal precox?
So we want to give the emphasis on the presence of abdominal distension without any edema. So possibility of some differential diagnosis can be made because on the basis of that abdominal
like for example, like for example.
Like constrictive pericarditis, even restrictive cardiomyopathy, as if there is involvement.
So you think constrictive pericarditis, restrictive cardiomyopathy will not have pedal edema?
No, sir. They have pedal edema, sir, in 1/3 to half, 50% of the cases. But usually, abdominal distension will come first in constrictive pericarditis or restrictive cardiomyopathy. They do have pedal edema, but if it is a negative factor,
I think this is a little too far-fetched, because finally pedal edema will also come. Well, agreed, pedal edema has not come yet.
No, I think, sir, they are making confusion. But in CCP, you will have first pedal edema or first abdominal distension. No, always pedal edema come first in CCP.
Pedal edema will always be there.
Who said you ki it's abdominal distension? So later on, it may be possible that patient may have, because of excessive diuresis, you may have less pedal edema and ascites, because ascites take time to recover. But initially, there will be always a pedal edema.
Yeah. The only, because otherwise, how I could understand that statement means there is something related to the abdomen, something else rather than cardiac. Because if it is cardiac, then you will have the trio together, and especially right-sided, you said. So you will have the JVP, pedal, abdominal distension, pedal edema. These things will be all together, largely. Okay.
I think it's a good point they're making, and we should allow them to make that point, because he is very clearly saying that this is what patient has complained. What can he do if pedal edema did not come?
No, madam. I am not saying that is incorrect. That is what patient is saying. That is fine.
Right.
But the point of discussion was, if there is an entity in cardiac settings where you get abdominal swelling without pedal edema. So that's what I was trying to discuss.
See, what they are trying to say is,
setting has
no, I don't agree. I think there will be CCP patients who have so much ascites that they don't even notice their pedal edema. It is nothing in compared to ascites. So very often patients come with abdominal swelling as the dominant complaint in CCP. So many times patients are admitted on gastroenterology and then brought to us because the JVP is elevated.
I agree with you. I agree with you.
So I think that these students should be allowed to make that point.
No. But what he is making in summary, the summary is his interpretation of the whole story.
No. He has not come to the diagnosis. No, this is summary. This is not diagnosis.
You're presenting up.
चलिए ठीक है.
आगे चलो.
मगर ऐसी कोई without not associated edema को इतनी specific importance नहीं दी जा सकती है, unless there is a specific entity where abdominal swelling only occurs.
I mean, I really don't agree with that. I have seen patients with constrictive pericarditis only having
you do see patients like that.
ascites.
Some form of endomyocardial fibrosis also.
Yes.
Ascites will be more prominent. There may not be pedal edema.
Right.
But it will be there. Without associated is not very.
Patient will not notice it. Patient is not noticing it. That is what we are saying.
Chaliye.
Yes.
Next. So what is the possibilities?
Yes, sir. Based on my history of the patient, my possible differential diagnosis would be, I would consider constrictive pericarditis as my first differential, followed by restrictive cardiomyopathy, valvular heart disease, in view of organic affection of tricuspid valve or carcinoid or congenital epstein, or cardiomyopathy, mostly RV or dilated cardiomyopathy, and lower down I will keep idiopathic pulmonary hypertension.
Okay.
On general examination, build is patient malnourished, emaciated, height is 132 centimeter, weight is 31 kg, BMI 16.7, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Pulse was 84 per minute, regular normal volume, no radioridal, no radiofemoral delay. All peripheral pulses were well felt equally. BP 118/74, mm of Hg in sitting position, in right arm, no pulses paradoxes. Saturation was 98% on room air. Respiratory rate was 18 per minute. Regular abdominal thoracic. Patient was afebrile during course of examination. JVP raised, pulsatile, 7 centimeter above sternal angle with prominent X descent and sharp prominent Y descent. Cosmal sign negative. Spine was within normal limit. On CVS examination, inspection and palpation. Bilateral symmetrical chest with normal precordium, apical beat in left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line, which is LV type, no visible pulsation thrills, no parasternal heave, no dilated veins over chest noted. On percussion, left heart border.
Can you be a little slow, please? Go back.
Yes, sir. On inspection
be
and
a little slow.
Yes, sir. On inspection and palpation, bilateral symmetrical chest with normal precordium, apical beat in left fifth intercostal space with 1 centimeter lateral to mid clavicle line, LV type, no visible pulsations, thrill, no parasternal heave, no dilated veins over chest.
So that is cardiomegaly, you mean?
Yes.
Yes, sir.
Okay.
On percussion, left heart border correspond to the apex, right heart border 1 centimeter lateral to right sternal border. Second, left intercostal space resonant, hepatic dullness in fifth intercostal space. On auscultation, S1, S2 normal with normal, S2 was normal with normal spec, no S3, S4 noted, no opening snap, no pericardial rub, no murmurs, and no pericardial knock were noticed. Other system examination, GI system, abdomen, per abdomen soft, non-tender, liver dullness from right fifth intercostal space in mid clavicle line to 3 fingers under subcostal margin. Septic dullness was present, however, no fluid thrill could be elicited. Spleen was not palpable, no bruit was noted. Respiratory and CNS system were within normal limit. So on the basis of history and examination of the patient, the summary is 16-year-old male presented with complaint of exertional dyspnea, abdominal distension, exertional fatigue, with examination, with positive examination.
Give us the diagnosis. No?
Yes,
we've said, listen to your examination.
Constructive pericarditis as my first diagnosis. However, I could not rule out restrictive cardiomyopathy at this point of time with congestive heart failure, NYHA 3, class 3, moderate ascites, no evidence of pulmonary hypertension, currently in sinus rhythm with no signs of infective endocarditis.
So I think you should make a diagnosis of restrictive heart disease rather than putting constrictive pericarditis, restrictive cardiomyopathy. Say restrictive heart disease, then you can choose between these two. First as CCP and second as RCM.
Yes.
Now, why do you choose CCP over RCM is what you have to explain.
Before that, can I just ask one question? You said it is restrictive heart disease. You said Kussmaul sign is negative. How do you explain that?
In percentage of restrictive cardiomyopathy, there may be Kussmaul sign may be negative.
You see, everything is possible. You said edema may be absent, Kussmaul may be negative. That is different, but you have to explain, na? By and large, in clinical medicine, everything fits. It is okay that sometimes you do get odd things, but everything cannot be explained by odds.
So between CCP and RCMP, where Kussmaul sign is more likely to be negative and how often is it negative?
It is, ma'am, is more likely to be negative in restrictive cardiomyopathy. In constrictive pericarditis.
So how often it is positive in RCMP?
1/3 of cases.
So I wonder why you have thought of CCP as number 1 and RCMP as number 2. You don't have Kussmaul sign. You don't have Kussmaul sign. You have cardiomegaly. You have written something else also, I thought.
After restrictive heart disease, as a clinical examination, once you make a diagnosis of restrictive heart disease, you should favor one amongst the two, constrictive versus restrictive. You get it? And I think these are what are the other features? One is that this Kussmaul negativity that you said, which is more likely in restrictive, I agree. What are the other differential? Can you tell us some of the other differentiating features on clinical which could have, which are probably there in this patient and you should favor one against the other?
Sir, there is a
cardiomegaly. What is a cardiomegaly? What does it favor?
Sir, cardiomegaly can be seen in restrictive cardiomyopathy in later cases when there is a LV dysfunction or.
No, is it seen in CCP?
Is it seen in my question? Yeah. My question is it seen?
Cardiomegaly favors which one amongst the two? You say that.
It favors RCM. It favors
That's
RCM.
all. Yeah.
Okay.
So on what basis? Tell us why you made CCP as number 1. That's all we are asking you. What has made you feel that CCP is more likely than RCMP?
Yes, by history wise, madam, that abdominal precox is more common in constrictive.
No, that is there in you just heard that Dr. Harikrishnan said that a lot of EMF patients come with ascites as the dominant feature. What else?
Ma'am, X descent is prominent here. In RCM, usually, ma'am, X descent is a bit blunted, ma'am, due to failure of RA relaxation. So prominent X and Y descent with features suggestive of in percussion also there was feature suggestive of right atrial enlargement also, which was again favoring
So
this.
RA enlargement favors CCP. RA enlargement favors CCP.
RC restrictive cardiomyopathy.
So again, you are giving me features which are of RCMP, but you are making a diagnosis of CCP, except maybe X descent. That's the only thing you've said.
Yes.
When will cardiomegaly develop in CCP? Will it develop or what situation?
In advanced stages of CCP, there may be cardiomegaly, sir.
There will be
Why?
cardiomegaly.
How it happens?
So as the natural history, as the pericardium gets more thick and calcified and everything, then you get dilatation.
But in
How could you
FUC
get
constrictive
dilatation?
pericarditis, cardiomegaly can be there.
Huh?
In FUC constrictive pericarditis, cardiomegaly can be there.
So that is a different thing. That's
FUC constrictive is, does your clinical findings suggest FUC constrictive?
No, sir.
What is the clinical feature of effusive constrictive? If there is fluid in the pericardial space in positive pressure.
Cardiac tamponade.
Which descent will go away?
X
descent will go.
X descent would be there. Y descent would not be there, sir. If it is behaving as cardiac tamponade.
So forget about effusive constrictive for the time being. You are talking of CCP and RCMP, and all your features excepting one, you are saying RCMP. So I don't know what makes you say, maybe you know the echo finding, that's why you're making it CCP. But clinically, at least from your history in your examination, RCMP scores over CCP.
Yes, ma'am.
Consider the age of the patient, the way he presented. All these things, does it favor CCP or does it favor RCM?
It favors CCP, sir. A young male presenting with typical features of dyspnea or which is chronic dyspnea followed by abdominal distension as a first, which and pedal edema is conspicuous by substance. So more likely a CCP.
But yeah, I will not agree to this feature. Please, whatever other examiners may think, I am very clear that pedal edema absent means constrictive pericarditis or restrictive heart disease is wrong. So whatever it is, this is my teaching to you. Rest you can go ahead, whatever you want.
No, we also agree, sir.
No. We were only pointing, we were only pointing out that in history, if they say that, we need to accept it. That's all I was saying. I'm not saying it doesn't happen.
This is a teaching learning message I'm trying to give them.
And the other thing is dyspnea class 3. You said, no? How often you get class 3 dyspnea in CCP? To begin with.
It was class 2 only this case.
Yeah, but his predominant feature was dyspnea, wasn't it? That was your history chief complaint number 1.
Yes.
Ma'am, usually CCP may usually dyspnea is usually exertional dyspnea class 2, ma'am. Usually class 3 symptoms, if at all develops, it develops very late during the course of CCP.
Yes, madam is emphasizing that because in CCP, dyspnea is less common and later on, but yes, in restrictive cardiomyopathy, more of dyspnea. And recurrent abdominal swelling is the presentation in case of CCP, and that can be associated with edema.
Yeah.
Rakesh, are we done with the time?
No, abhi hai, ma'am. Abhi we have just 25 minutes.
No, we can save some time. This is a shorter case.
We can go to the
ECG. Can we see the ECG?
Yes.
Maybe just tell me. We
have 15 minutes more, sir, for this case.
Can ECG help us differentiate between constrictive and restrictive?
Yes, sir.
Yes,
you have only taken 20 minutes till now.
Before we see the ECG, I want you to tell me that if it is constrictive, what do you expect on the ECG? And then we will see.
If it is constructive, sir, constructive pericarditis, we may find normal ECG. We may find ECG with low voltage QRS. We may find ECG with generalized T wave.
How often do you get normal ECG in CCP? You started off with normal, so how often the ECG is normal in CCP?
Ma'am, I'm really not sure of percentage, ma'am.
Okay, take a guess. Take a guess.
Ma'am, in less than 50% of it is low voltage complexes, and
no, my question is very simple. Why do you beat around the bush? In how many percentage of CCP ECG is normal? That's the question. I'm not asking low voltage, STT. These are all abnormal, no?
No, ma'am.
How many will
Percent
have a
have
normal
eroded,
ECG? Sorry?
More than 50% of the cases, ma'am.
Absolutely
Normally,
wrong.
no,
Absolutely wrong.
no. That is incorrect.
Absolutely wrong.
Absolutely.
Absolutely incorrect. Less than 10% of cases have normal ECG
Yeah,
and
yeah.
CCP.
You'll
So
always have
CCP, ECG has some abnormality or the other. It could be just left atrial enlargement. It could be just STT. It could be low voltage. But some abnormality will be there in 90 to 95% of cases.
Yes, ma'am.
Yeah.
Or Dr. Goel ka kya question tha? Sorry, I was just interviewing.
So let's see. So that's what. And what about the RCM? What is the type of ECG that you will get in RCM?
Sir, in RCM, we will be getting biatrial enlargement, sir. We may
Yes.
get low voltage QRS if there is infiltrative RCM, infiltrative disease. We may get rhythm disturbance in RCM, sir, and yes.
So rhythm disturbance will be more common in RCM or constrictive?
Sir, rhythm disturbance would be more in RCM, sir. In CP, less than 10% cases have atrial fibrillation.
Okay, let's see the ECG then. Come on, let's see. So we'll see what features are there.
Sir, this is a standardized 12-limb ECG showing normal sinus rhythm with a rate of 76 beats per minute with features of with QRS axis of plus 90 degree with features of biatrial enlargement. With negative, this B1 is biphasic P with lead 2 showing lead 1 showing classic humped P. So it is biatrial enlargement.
You think
By this ECG, what is your first diagnosis? Restrictive or constrictive? By this ECG?
Sir, I would go with restrictive, sir.
Bilkul.
You see, for I don't know, the constrictive ke liye, this is
maybe
a little higher voltage, I would say.
You didn't say about STT changes. There are STT changes also.
Yes, ma'am. V2, V4, V5, V6, ma'am, there is STT changes.
Yeah.
The atria are so dilated.
Yeah.
Biatrial enlargement. Okay.
Yes, sir.
X-ray?
So this is normal X-ray PA view with which is slightly rotated, showing cardiomegaly with LV type apex. CT ratio is 0.63 with normal carenolus playing angle is not enhanced with sign of right atrial enlargement with no sign of pulmonary hypertension, venous or atrial hypertension.
I don't agree. You say no pulmonary venous hypertension.
Ma'am, syphilization, yes, ma'am.
Yeah,
grade 1
LA, what about LA?
Pulmonary venous hypertension, ma'am.
What about LA? Is LA enlarged or not?
Sir, there is no double heart shadow, but this carinal angle is normal.
What is the carinal angle?
Sir, it is around 70 degrees, sir.
I think it is more than that.
It is normal.
What about the ribs show something?
Pardon, sir?
So there is cardiomegaly. We were discussing about the presence or absence of cardiomegaly.
Yes, sir.
So the cardiomegaly is there?
Yes.
Yes, sir.
Is there any evidence of effusion?
Sir, no, sir. This cardiophrenic angles are clean and there is no cardio. Yes, sir. There is no signs of effusion inside.
CCP or RCMP?
Lateral view, what does it show? Lateral view, what does it show?
So lateral show, sir, it is showing
which chamber enlargement?
There is no calcification as such in lateral view, and it is showing biatrial enlargement.
What is your final diagnosis after ECG and X-ray?
Sir, I would go back and revise my diagnosis as RCM as my first diagnosis rather than CP because my finding is more in line with consistent with RCM.
Okay. What does the echo show?
Yes, so this is subcostal view showing dilated IVC, and the second one is the video is playing, sir.
Yeah, video is playing. We can see.
The second one is AM mode showing there is no respiratory variation. So
What does it indicate?
so it indicates it could be either in CP and RCM both, sir. This is parasternal long axis view showing this left atrial enlargement, and this
Run this view. This is not parasternal long axis view. Run this. What is it that you are seeing here? Are you seeing aorta?
What is this view?
Just run it.
the video is stuck, ma'am.
No, it's not stuck. You click here. You click on that bar, on the opaque part of the bar. Yes.
Yes.
What
Ma'am,
is this view actually?
This is RV in flow view actually, ma'am. It's not parasternal long axis view. Showing thin rhemopericardial effusion with normal mitral valve with normal LV function and normal tricuspid.
What about the ventricular muscle? Yeah, LV
Yeah,
muscle.
that is the most important thing you should say.
Yes,
Now, when you are saying
ventricular
your
muscle.
diagnosis is RCM, you
Yes,
should
ma'am.
say about the ventricular muscle, no?
Yes, sir. Ventricular muscle is thickened, sir.
अरे थिकेंड तो क्या भाई हाइपरट्रोफी है, कुछ तो बोलो.
Hypertrophy, sir. Hypertrophy.
हाँ, तो क्यों थिकेंड है? तो अलग से सबसे पहले वही चीज दिख रही है. You didn't comment on that at all.
Did you do you want to see? Do you want to see any other area of the myocardium?
What about the RV? RV is not seen as well here.
Yes, sir. There is another view for RV, sir.
What about the atrial septum? Do you want to see specifically?
Sir, this is LV, sir, showing.
There is hypertrophy. There is certain.
Yeah, hypertrophy, sir.
And what else is there? There's something else also. Yeah. What do you see on the? This is a good view, a good picture. I don't know whether.
This is short axis.
Can you comment on the endocardium? How is the endocardium?
Sir, endocardium little brightening is there.
There is some brightness, sir, endocardium. There is some.
You should say that, na? You are
Yes,
presenting the case. You are not telling those things. So
this is a apical fourth chamber view, sir, showing biatrial enlargement. And this one showing color flow across tricuspid valve, showing moderate TR.
what else did you do to on that TR?
Yes,
Pardon, sir?
What else did you do on that TR? You
Yes,
said
sir. We have taken this.
to say that. What is the RV pressure?
38 mmHg.
कैसे 33 9
Then
3 मीटर तक तो उसकी वो वेलोसिटी आ रही है इसमें.
So if you are getting 3 meters, what will be the RVSP in this patient? Your clinical
3 मीटर आ रही है तो कितना होगा RVSP?
38 plus 20. IVC is added. Plus 20, sir.
Plus 20.
Plus
ये
15.
किसने बताया?
Plus 15, sir.
Plus 15.
Yes, sir.
ऐसे थोड़ी होगा भाई. There is a norm that we follow. Agreed, this patient may have some higher pressure, but we usually follow the norm of adding how much on the RV, on that TR velocity.
Sir, if the IVC is more than 21 millimeter and it is non-collapsing, then that cases we can add 15 millimeters.
Okay.
What about JVP? What about JVP? How much was it?
So
How much was
36,
JVP?
JVP was 7 centimeter.
Only?
7 इन्हीं से तो पूछा था 7 and 5 12.
नहीं वो
7
दूसरे
centimeter
पिछले वाले से
external angle.
पूछा था. हम कंफ्यूज होते जाएंगे.
So इसका JVP कितना बताया था आपने? How much did you say?
7 ही था इसका भी.
7 centimeter of S2.
7 वाला ही था.
Okay, so 7 plus 5, 12. Okay, all right.
So do you want to mention some negative findings in this?
नहीं तो तुमने 38 कैसे कैलकुलेट किया? Just a second. You told us 38. How did you get to that 38 figure?
So velocity.
We have not added, sir. We just add velocity.
So 3 velocity means 38?
36.
36. Okay, all right.
You have to be very exact. You know, we can't be sort of fooling around. You know, whatever is exact is exact. And then, of course, there is subjectivity in everything. Okay.
So there was some other question, Dr. Hari Krishnan. Yes.
Yeah, do you want to look at any other area of the heart to see any hypertrophy or infiltration?
Yes, sir.
Interatrial septum you have to see, sir.
Yeah, that is why you say the negative finding
Yes,
always.
sir.
Yes, sir, we have
Interatrial
seen
septum
that.
Now
record.
you should
Yeah.
tell the negative finding. You're not telling that negative or positive, whatever.
Yes. Next.
Okay, what other next investigation will you do? You have completed the echo?
No, sir.
No, sir.
Oh, sorry.
Okay, yeah, go forward.
So,
What about the Doppler finding?
Yes,
What
Yes, sir, it is coming, sir.
yeah,
sir, we have seen mitral inflow velocity. So,
E and A.
E and A we have calculated is ratio is around more than 1.8. So it is again it may be in both constructive as well as restrictive. So we did tissue Doppler, which was E prime was less than 5, and E prime was less than 5. So it favors the diagnosis of RCM over CCP. And there was
where will you take that issue?
What is the E by E dash ratio cutoff for RCM versus CCP or whatever? There is a E by E dash. It's not in absolute, no? It's
Yes,
E
sir,
by
more
E
than
dash.
15,
Is that
more
correct?
than
More than
15 is
15.
favoring of restrictive cardiomyopathy.
No, but
Where
what
will
is
you
that?
take where will you take the E prime in a constriction?
Constriction, sir, we will take mitral annulus, sir.
Medial
Medial
leadership, we have
annulus.
to
Medial.
take where that mitral medial leaflet where it is getting attached to the interventricular septum. That point.
Okay,
Okay.
yeah.
So there were no inflow variation, significant inflow variation across tricuspid valve as well as mitral valve. There was no more than 40% across tricuspid valve and no, less than 25% across mitral valve. So it was.
You mean it is a respiratory variation you are telling?
Yes, sir. Yes, sir.
Okay, yeah.
And there was the TAPSE was around 13. So it's a bit RV dysfunction. VP, I could not get that slope of VP. It is more of strand, so I could not interpret VP, velocity of progression. And
Okay.
there was no interatrial septum was intact, and on strain the value was suggests again favoring RCM over CP. It was minus 10.3.
Okay.
So we did. Yes, sir. Yes, sir.
Yeah, go
Do you need
forward.
to catheterize this patient?
Pardon, sir?
Do you need to catheterize this patient? No. Yes or
Sir,
no?
on the basis of this echo parameter, sir, this echo parameter was favoring RCM. So we will be needing imaging rather than catheterization in this patient, sir. Because in 2D echo modality only we are sure that it is RCM. So we want to know the etiopathogenesis of causes of RCM. So we will go for MRI rather than cardiac cath.
So what will MRI tell you about the causes?
Sir, MRI could tell us about myocardial infiltrative diseases like amyloidosis. It tells us about subendocardial enhancements like in sarcoidosis. It may give us diagnosis of EMF also, sir, because it will clearly show RV apices and RVOT area. So it will really help us to categorize what kind of RCM the patient is having.
But the EMF and all is very clear in this. No, there is echo,
Yes,
there
yes,
is no RV optical obliteration. So
Yes,
basically, you want to see what you want to see the character of the myocardium.
Sir, we did this anti-pro BNP also, sir, which was around 5,560. So again, it was favoring RCM over CP. So by this, sir, we will go with the diagnosis for RCM first, and we will order cardiac MRI as our next line of investigation.
You have a cardiac MRI?
Was the MRI done in this patient?
Sir, cardiac MRI is still pending. So patient, we received patient just 2 days back only, sir.
Okay, so how will you manage this patient if cardiac MRI shows some infiltrative cardiomyopathy?
Sir, we will medically manage heart failure symptoms to begin with. diuretics with low salt diet. And along with that, we may use with cautious, we may use ACE inhibitor and beta blocker with cautious, and we should avoid using desoxin in the patient. So first line would be medically stabilizing the patient and try to do MRI and to find the etiology of RCM, and accordingly we may proceed further, sir.
What are the treatable conditions which you can come across?
Sir,
RCM.
treatable, yes, sir. If it is due to any connective tissue disorder like sarcoidosis or scleroderma or sarcoidosis, these kind of diseases we may treat. If it is amyloidosis, now amyloidosis, there are few treatments for amyloidosis at for now, but I'm really not sure how, I mean, how the patient.
What type of treatment is available for amyloidosis?
Sir, there is, to begin with, we may use bortezomib in the amyloidosis patient.
What did you say?
Bortezomib, sir.
No, what type of new treatment which has come in amyloidosis, and what type of, how will you characterize that?
Sir,
sir, tetramer stabilizers are available now, sir.
Okay. So is this age group of those patients who this drug will be effective?
So this is not the age group for presentation of the common one.
So this is very likely, unlikely age group to present an amyloidosis, because 4 type of amyloidosis is a primary senile amyloidosis. They usually present after 50 to 70 years, which is very unlikely to be.
So how will you confirm the diagnosis if it is some
we will go with less invasive modality like abdominal fat pad biopsy, or in few cases we have to go for this cardiac biopsy also, but we will go for abdominal fat pad biopsy to begin with.
Okay. So will you screen the family?
Yes, sir.
Means what? How will you screen, and why screening is required?
Screening is required for the few.
No, how will you screen? Because this patient has come with at an young age, he has come with a recessive cardiomyopathy probably. And how will you do the family screening, and what will you do?
We may go for 2D.
How will you screen? Who all will you screen? What all? How many? What is it? Level of relatives will you screen?
Second degree.
What how many generations?
Second.
So because the genetic, there is a possibility of some genetic diseases and even restrictive cardiomyopathy. Mostly first degree relative will screen for history, examination, and transthoracic echocardiography.
No, at least you screen who all you should screen. Screen his parents, his siblings, and if he has children, his children should be screened.
Yes, sir.
Okay. And how will you do the screening? Will you do a genetic analysis?
First, we can do an clinical and the echo screening we can do.
Okay. Screening is done and nothing is found. So are you happy, or will you continue the follow-up?
Continue the follow-up, sir, because they might present late. So there is incomplete penetrance. Yes.
Okay. So if you do a next generation sequencing and find some genetic abnormality, what will you do in this patient? Will you screen the family members?
No, sir. We would keep those patients under follow-up, sir, for strict follow-up, and we may.
What you do is you screen the family members if they are if this patient has a positive genetic factor or a genetic mutation. What you do is you screen the family, And if somebody is positive, you screen them continuously for the development of the disease. If they are negative, they can be kept, they need not be on regular follow-up. That is how it is planned.